slides up. So we're going to talk about it for about 30 to 40 minutes. But please, if you have questions or comments at any point while I'm speaking, just jump in. I can only see the slides, so Kim is going to let me know if you chat in a question, and we'll stop and try to address it right then. So please feel free to be as interactive as you like. And then there will be time at the end for us to have a discussion or answer any questions that this topic brings up. This is really intended to be kind of an overview of the history of treating substance use disorders in a nutshell. And Kim is also going to be sending you a couple articles that I will mention. One is a really well put together comprehensive history that goes all the way back to like the 1500s. I really recommend that you take a look at that article. And then the other one is a nice article that came out of the MATCH project, and we'll talk kind of briefly about that once I highlight it in my slides. So you'll be getting all of that plus these sent today?
Later on today.
Later on today.
Yeah.
Okay. Okay. Fantastic. So again, please jump in if you have any comments, thoughts, or questions. All right. So the first thing that I like to do to get started with this topic, and I would just encourage you to sort of think about this question. You don't have to chime in and answer, but just think about, how do you handle stress? And I love cats, so I have to have my cat representation of how I handle stress. But just sort of think about, in general, when you're stressed, when you're distressed, when life is getting hard to handle, what are the types of things that you do? Oftentimes I hear people say, you know, I binge watch Netflix, or go out with my friends, or have a glass of wine with my partner. I go for a walk. I go to church, right? So we sort of think about, do you need to do anything? Do you need to close that? Okay. We sort of think about how you would tend to manage those things. And now I would like to encourage you to think about this. What if somebody just told you to stop doing that thing? Just stop. You can't do that anymore. Or what if they took it away? The one thing that really helped you or made you feel better. Or what if they punished you and put you in jail for doing that one thing? The thing that seemed to help you manage your difficult life, your painful emotions, the thing that helped you to cope with family stress, work stress. How would you handle that? Or what if you felt like a bad or broken person for doing that one thing that gave you comfort, made you feel less lonely, anxious, sad, or afraid? Right, so just kind of hold whatever feeling comes up for you in going through those questions. Whatever emotion you might have as a reaction to, if that thing that I find most helpful was taken away from me, if I was punished, or if I felt like a bad person for doing it, how that might affect the person that I am. And sort of think about that as we walk through these treatment perspectives. So let's talk about addiction treatment in general. Sort of how we have viewed addiction treatment throughout time, because substance use, misuse, abuse, addiction, it has been viewed and treated differently within the United States across time. There are a lot of similarities, but in general, we can sort of categorize it as it's been viewed as a crime. So there's been lots of social movements, different treatment programs that have said addiction is something that impacts society. So we have to deal with it socially and remove those people from society. Movements that have held this viewpoint are things like the temperance movement, or those of us who remember the 80s, the war on drugs, right, the Nancy Reagan campaign. Addiction has also been viewed as a moral problem or a moral failing. So viewing that addiction really is the result of a lack or failure of willpower or a weak character. And this literature that really has no scientific backing behind it, this idea that there's such a thing as an addictive personality, that person is somehow morally more weak or unable to make the same decisions as other people because of their personality or because of just how they're wired, and it's always going to be that way. So the statement, once an addict, always an addict, that's coming from this viewpoint. We also have had periods of time where we viewed addiction as a disease. And we're sort of in that point right now in history, but we've been able to expand on it. And by disease, I mean something that has a direct cause and effect relationship. So I break my leg, what do I need? You know, that's a result of a fracture in the bone. I have to now put that leg into a cast, or maybe even do traction or physical therapy to heal that leg. But once it has been reset and healed, there's a end to that process. So sort of thinking of disease in that sort of, there's a cause, and then there's an effect, and there's a direct treatment or intervention associated with it. At this point in time, we've been able to expand on that and say, yes, there's a disease process at work, but addiction is actually more complicated than just this straightforward, I put drugs in my body, my brain becomes addicted, and therefore I develop an addiction process. Addiction is really considered a complex, multifaceted condition or illness, in the sense that it has psychological, physiological, social, and environmental contributors. So if we think of it as really it is greater than the sum of its parts, right? That it is not as simple as I put drugs in my body, if I remove the drugs from my body, disease is cured. It's really not that simple. And those of us who work with this population are very, very aware of that. So let's just kind of take a few minutes and go through the history, because I think this is important to be grounded in when working in substance abuse treatment, because this history follows us, right? And you're going to start to see echoes of it as we work through some of these components. In the 1800s was really when we started to, as a society in the United States, think that we needed to do something about substance use issues, particularly alcohol. So the pre-20th century, actually pre-1914, all psychotropic drugs were legal. So there was no such thing as legal or illegal drugs. In 1914, this thing called the Harrison Act came about, and that is what criminalized certain drug use or sale of particular drugs, and sort of the rating system that we still have now in terms of what level, like class 1 through 4, and what type of drug or illicit drug it is. During this time, in the 1800s, most treatment was focused on isolating addicts, and I put that in quotes, from society to protect others from the addicted addict's moral failing. So it was a definite moral perspective, and particularly those that were addicted to alcohol. And the temperance movement was an example of this, where they were viewed as problematic to society, that they caused violence and degradation of society and families, and that they needed to be removed. And so during this time, when someone was identified as having an issue with substance use, they were either sent to prison, to asylums, which were very unpleasant in the 1800s, or halfway house type settings, sober communities that were sort of in farms or rural locations on the outskirts of town. They were removed from their families and from their communities. Most available treatment was focused on alcohol, because that was considered the primary drug of abuse. But towards the later end of the 1800s, 1880s, 1890s, opiates and cocaine derivatives, different tonics, different sort of treatment regimes that doctors would prescribe became popular, particularly for women, for this phenomenon of female hysteria. And so therefore, a lot of these white, educated, higher society ladies became addicted to opiates. So laudanum was a particular one, or various different derivatives of the poppy plant. And so what started happening, interestingly, is physicians started saying, well, this idea of somebody having problematic behaviors as a result of taking a drug, maybe we're not quite right about that. Maybe we don't need to send them to a prison or an asylum. Maybe there might actually be a non-moral disease process at play. So then we see the uprising of these things called sanitariums, which if you had some money, you could go to. The founder of the Kellogg, one of the Kellogg brothers, was well known for a sanitarium that he started in the 1800s, which would treat things like opiate addiction or alcohol addiction. So I just think that's an interesting thing to note, that when substance users were considered to be sort of that lower SES, they were really pulling down society, we would send them to prison. But as soon as, the higher echelon, mostly educated, mostly white women started developing these problems, then treatment started to shift and we looked at it differently. So that's just an interesting side note of how culture and society has played a role in some of what we've done. Now we enter the 20th century. So this is particularly from 1900 to 1933, 1934. So this is pre-AA. What started happening was these sober houses began to pop up to treat alcohol and other drug uses, and they began to be favored over asylums and prisons as the primary intervention. So if you think about sort of the halfway house, or even some of the sober houses that we have today, began during this era. So go and live with other people who are trying to manage an addiction together. The moral failing model definitely remained in place, and there was a continuing of criminalization of drug and alcohol use, particularly for those who were poor or of minority backgrounds. Organizations like the Salvation Army and other religious groups really started to come about, and they echoed this moral failing model, and that their treatment regime was focused on helping restore the moral character of those with an addictive disorder. And in fact, when people would be incarcerated, they for drug-related issues, they would be mandated to treatment. So they would be pulled out of the prison system and sent to these things called narcotics farms, which were sort of long-term treatment, long-term as in years, for fulfilling the requirements of whatever their drug offense was. And the history of methadone began on one of these narcotics farms. Sanitariums and health recovery-based institutions pretty much largely dried up during this era. So there was a short-lived window of time, and between the early part of the 20th century, they pretty much disappeared. Like I said, the criminalization of drug and alcohol use continued, and during this period is just of note. Our field decided to experiment on the correctional facilities to figure out this disease of alcohol use or drug addiction, and say, there must be something that we can do to treat it. Let's experiment on a captive audience. So there were a lot of really significant ethical violations and concerns about our history of how we have treated the incarcerated population. So things were done like insulin-induced comas, electroconvulsive therapy, aversion therapy, so giving someone a drug and then giving them alcohol to make them sick, so that they would associate the sickness with the drug use. Even things like lobotomies and sterilization were experimented on in this population. So it's really kind of a dark time with how we attempted to treat substance use disorders. Then we get to from 1935 to 1980. This is when we see the AA comes along, and I believe it's 1935. The big book gets published, and then out of that model comes the Minnesota model. So AA, I'm sure most of you are familiar with, was founded in 1935. This is a peer-led group program for alcohol use disorder. This program provided community-based, anonymous, widely available support for self-guided recovery. So it was very widely adopted, easily disseminated, sort of step-based program. Then in 1948, it's about 10 or so years later, Wilmar State Hospital and Hazleton, which is some of those you might know as the Betty Ford Clinic, developed this thing called the Minnesota model. And that was a program that took the first 5 steps of the AA program and combined it within other elements of a residential program, which also would include some medical treatments. So this model is really where the professionalization of substance abuse treatment came about. So through the development of the Minnesota model, they started to sort of see that we need a specialty field, not just general medicine or not just general psychiatry or general therapy, but we need a specialty group of people that have specific trainings to be able to provide targeted substance abuse treatment. What they thought at the time was that we needed we think about now sort of peer support folks. We need drug counselors or like LADAC type drug counselors who have been in recovery themselves, and that they should be the primary intervention. This was thought to be necessary for optimal treatment. So saying that we need to match people, that the therapist needs to have struggled with the same substance as the patient, that the therapist or the counselor should be of the same gender, of the same race. So ideally that this match is what's necessary to help people recover, because, and a lot of this comes out of the AA literature, right, that only an addict can be understood by another addict. Now, later this was disproved in a large-scale study called the MATCH study, which I've included that article for you to read, which really found that's not the case, that MATCH is not necessary, and in fact, really excellent intervention can be provided by someone who's never had an issue with addiction. So I just think that's an interesting note, that sort of that emphasis of we really need people who struggled with it themselves to be able to help people with a substance use disorder. Not to say there isn't a place for that, but that's not necessary to be able to provide excellent substance abuse treatment. One thing to understand about this period in time is this Minnesota model and the AA model were widely disseminated. In fact, the Minnesota model was adopted by 114 state agencies by 1971. And so this is one of the reasons why AA literature and practices are still so pervasive today in most substance use disorder programs. Even though there's a real lack of consistent evidence that this model, the AA model or the Minnesota model, is appropriate for all substance use disorders or populations. And there is some evidence that even says it could be harmful for certain populations, particularly women and ethnic minorities. And so that's just something to keep in mind if you work in a program where the 12-step model is the only model. It could be because it's coming out of this history. And that's just something to think about. Maybe that is not the only model that you could implement in your program to widen the options, because we now know that people with substance use disorders cover a huge range of issues and needs, and there is no one-size-fits-all treatment. Then we enter the period of 1980 to the 2000s, which is the war on drugs. So this is where we really see a huge uptick, probably the largest uptick we've ever seen in criminal justice involvement. This is when drug court models began. About 40 to 50% of community referrals for treatment occurred because of this drug court model. So for those of you that might have been practicing in the 1980s to the 1990s, or for those of you that might have attended even something like an AA group at that time, we went from one population of people seeking substance use treatment to a huge influx, about a 50% influx of folks seeking substance abuse treatment, not self-referred, but through mandated drug court or criminal justice mandates. So that's just an interesting thing to understand some of the patients that we see today and some of the history that is still impacting drug courts and judge decisions started during this time. The other thing to understand is, as a society, we began to incarcerate drug-related offenses, or what's called CDS-related offenses, at a crazy high number. So we went, it was an increase of about 1,200% during this time period. So we went from about 40,000 people incarcerated for CDS-related offense in 1980 to more than 500,000 by 2018. So that's a huge shift as a society. Yes, we've always had that moral failing model and that criminalizing model in place in society, but during the war on drugs period, we saw that a huge shift to where that became really the primary way of dealing with people with substance use disorders, was we incarcerated them. This is also when we saw the Just Say No and the War on Drugs campaign. We still see that today. It still blows my mind that there are DARE programs in the community, because there is lots of research that has shown this can even have a harmful effect, that this type of tactic of just say no, just stop, just don't do it, is either completely not effective whatsoever, or it will cause an increase in drug use, or likelihood that people will use drugs. So we saw some results of that particular campaign. This is also where we saw a shift to managed care, sort of dictating treatment recommendations. So this idea of the 28-day rehab or the 30-day rehab, the 28 days was an arbitrary number that was capped by managed care. So the insurance companies decided, oh, that's all you need. You need 30 days to recover from a substance use disorder, because that's all we're going to pay for. But that was not based by science. There's actually a lot of evidence, and we're going to talk about that in a few minutes, that substance use disorders are chronic illnesses, and they require chronic care management, which is long-term care. So that's just something to keep in mind where that particular thing came from, and it started in the 80s and 90s. Another big thing that happened during this time period was we started looking at a lot of animal models for substance use disorder, and starting to understand the impact of social isolation, so what's called the social model of addiction, and a lot of that work began to be published. And so I want to just, for those of you that are not familiar with this particular research, you're probably familiar with the concept that at one point in time we did a lot of studies where we put rats in a box, and we gave them a water bottle, and we gave them a bottle that had heroin or alcohol or cocaine in it. And then we watched what they did. Well, what did they do? Well, the rats always chose the drug-laced bottle, and they would choose that over food, over sex, over water, and almost always would they die. So there was a almost 100% overdose rate associated with that choice. So what we began to think as a field was, well, that's what drug addiction is. That if I expose somebody to a drug, they're going to become addicted to it, and they are always going to choose that drug over everything else, and they are going to use that drug until they die. That's how addiction works. So that's why we have to remove them from the drug. We have to isolate them. We have to get them away. So basically take the rat out of the cage so it doesn't have the choice between the water and the bottle that has the drugs in it. Well, this guy Alexander came along and he goes, wait a minute, this doesn't seem quite right to me, because rats don't live in a cage by themselves. Rats are social creatures that in the wild, they're not isolated. So this isn't a true experiment. This isn't showing us where choice comes into play. This isn't showing us the contextual variables that are important to be able to understand what that is doing in terms of addiction. So he said, we gotta put rats in an environment that makes sense to the creature. So they created this thing called Rat Park, which was a big, huge cage, and it had a bunch of other rats in it, and a bunch of toys, and a bunch of different types of food. And so the rat could do a lot of different things. It could play, it could have sex, it could eat a bunch of different food, it could sleep, it could basically socialize and interact in a lot of different options. And then they did the same thing. They put the water bottle and they put the drug-laced bottle in Rat Park, and what they found is the rats would still use it, the drug-laced bottle, but they'd only use it occasionally, and they almost never used it to excess, and they never overdosed. So what does that mean? That implies that we've been focusing on the wrong thing in terms of addiction, that it might actually be the case. It's less important that we focus on whether someone is using a drug or not using a drug, and we focus more on what their cage looks like, right? How isolated are these people? How engaged in life are they or not? That might be the variable that we want to focus on more than are they using or not using. So I think that's really important research that came out during this time period to be aware of. In correlation with that, the harm reduction model for social health evolved, and this is the kind of model that says, you should wear seatbelts, you should use suntan lotion, do things to be as healthy as you possibly can be. Well, this model was then applied to substance use populations, and allowed for medication-assisted treatment really to become mainstream. So a lot of the ORT or medication-assisted programs, they fall under this harm reduction model, which was developed during this time period. So what does this tell us? Our history of treating substance use tells us a couple really important things. It tells us that we viewed addiction as a moral failing for a long time. For almost 200 years, right, or longer. We've poured large amounts of resources into removing addicts from society rather than offering them treatment. We have disseminated and prioritized abstinence-only models, and those that fall under the auspice of sort of the AA teachings or a step-based teaching, despite research that says there is no one-size-fits-all treatment, and that harm reduction models are just as important and sometimes more important depending on the patient and the patient's needs. We've also shunned, stigmatized, and misunderstood people and placed way too much emphasis on this thing called willpower and choice, rather than giving people realistic options and helping to support them so that they can develop really the skills that they need to overcome this very serious and complicated condition. Because it is not as simple as taking the rat out of the cage so it's away from the drug, that in fact it really is thinking about that rat park. How do we help them to build a world or to build a life where they can make a different choice? So quick pop quiz before we get into the science and all of the current knowledge that we know about addiction. Just think for a second, how many years have people abused substances? And if my picture doesn't give it away, I hope all of you are saying, well, as long as human beings have been on the planet, because that's about right. Our oldest accounts, including primitive cave wall drawings, hieroglyphics, the Bible, the Torah, and our Dead Sea Scrolls, they all have accounts of human beings using psychoactive substances. And I love this picture because they're obviously having a good time. So I think that just says something that this isn't a subset of the population. This isn't something, when we think about that that incorrect, like addictive personality or these people being somehow different types of humans. No, actually addiction or the propensity for addiction is part of being human. And so understanding how long it's been around is an important piece of information. So what do we know now? Let's talk about present day information. What we know is that people take drugs for a variety of reasons, that it is not just one thing, and that it might be multiple reasons that allow or that are pushing them to take drugs or not take drugs. One of the main reasons that people use psychoactive substances is to feel good. That if a drug is to be abused, most of the time it produces some kind of an intense pleasure feeling or feeling of euphoria. But drugs differ by their secondary effect. So for instance, cocaine has an initial euphoria followed by this feeling of like power, grandiosity, self-confidence, and increased energy, versus opiates, which have that same initial euphoria, but then it's followed by a feeling of relaxation, sedation, and satisfaction. So depending on what it is that the person is seeking to feel good, it's that initial, yes, it's the euphoria, but it might also be those secondary effects that they're seeking. People also take drugs to feel better, and this is probably the one that we deal with the most by the time somebody develops a substance use disorder and they get to us, that they've bypassed the point where the drug is creating the euphoria. Now they're in a withdrawal, a dependence cycle. So they're going from intoxication to withdrawal, and they're using the drug to fend off the withdrawal. So what they're trying to do is to feel better or to feel normal. Oftentimes people will get into this particular pattern as a way of helping to deal with anxiety, stress, PTSD, depressive symptoms, grief, loss. What they're trying to do is not necessarily to feel good, but to not feel bad. And understanding that stress plays a huge role in this particular pattern. And it's one of the reasons why stress is such a common trigger for relapse or return to use. People also use drugs to do better. Some people will, we think about anabolic steroids or people abusing amphetamines like Ritalin or Adderall in order to stay awake, to study for a test. That's all in the service of trying to perform better or improve performance. We also see this in the OUD population. So those that have developed an opiate use disorder, they're taking a chronic depressant. They might supplement sort of the way we need to have our coffee in the morning. They might start to add things like methamphetamine or cocaine or even prescription amphetamines like Adderall into their daily regime, not necessarily to get high, but to wake up and to be able to vacuum their house and take their kids to school, right? So it's an attempt to do better or improve performance that they might be adding that secondary drug on. And then the other reason why people commonly use drugs is for curiosity, which as human beings, curiosity is one of our core emotional experiences. So it's hardwired into us. And when we see people around us that are using a drug, that will make us want to see, what does that feel like? So this is where we get into the vulnerability for adolescents, which is one of our most vulnerable populations for starting to use drugs. Not just for peer pressure necessarily, but also in the communities and the homes in which they might be growing. So that's where we see sort of this normalization of substance use. I know where I work, we will see multiple generations where we have grandma and mom and daughter all getting treatment at the same time because it really has been normalized in their subgroup that this is just what you do. You get to a certain age and you start using heroin. So that's where that is playing in. Sort of, well, that's what my mother does. That's what my grandmother does. I'm going to try it too. Now, in terms of this feel better model, like why I might be doing it to eliminate some form of distress, this is called the coping mechanism theory. So it's pretty straightforward, right? If I have a strong negative emotion, there's going to be tension there to try to eliminate that negative emotion. And if I don't have a easy to access, well-practiced coping mechanism to eliminate that negative emotion, what am I going to do? I'm going to use a substance because it's pretty efficient. It works almost instantly, and it's a lot easier to get my hands on. And if I don't have any other skills or any other options, then I'm just going to return to that to eliminate that negative emotion. What happens is it reduces that tension. It reduces the negative emotion. So I feel temporary relief, but then as soon as the drug wears off, I get a return of the negative emotion, so then I have to use again. So this is the coping mechanism theory of why people will end up developing a dependence pattern relatively quickly. So what causes addiction? What do we know at this point? We know, again, that this is a multifactorial, very complicated condition, and there's no single factor associated with it. Current science suggests that it's really a combination of risk factors and protective factors. So we can see risk factors are things like poor social skills, experimenting with drug use, particularly before the age of 25, availability of it, experiencing things like community violence, community poverty, lack of parental supervision, engaging in any kind of aggressive or a liable emotional expression. And then protective factors tend to be the opposite of that, feeling competent in either your work or your school, having a sense of community pride, having good parental monitoring, having the ability to delay gratification. So other factors that are really important to understand is the genetic contribution. We now know that close to, or depending, around 50% of the likelihood that someone is going to develop a substance use disorder is genetically correlated. This is a higher percentage than other things that we commonly assume are related to genetics, like high cholesterol. It's much higher than most cancers, that when we talk about, cancer running in families, and we seem to have no social stigma about that, but for some reason with substance use, we always forget about this particular component. And this is really, really important because, you can't do anything about this, your genetic predisposition. The other thing we know that is extremely important is the age of use or exposure of use. So about 96% of individuals who go on to develop a substance use disorder began using substances before the age of 21. So you cannot underscore the importance of age of first use. And I know where I work, a lot of my folks started exposing themselves or exposing their brain to substances around the age of 12 or 13. So significantly before their brain is completely developed. And that is going to have long-term impacts. Repeatedly engaging in the drug. So the more I expose my brain to it, the more likely I'm going to end up becoming dependent on it. Disruption of healthy social support. So not having good, again, that my park is really isolated. Not a lot of good social supports, and interpersonal problems are very highly correlated with later addictive conditions. This is a really big one, exposure to trauma or stressors that overwhelm an individual's distress tolerance. So if we think about people that might grow up in communities or homes where there's a lot of violence or where they're exposed to repeated traumas, they're going to be much more likely to go on to develop a substance use disorder. And then having things like distortion in meaning, purpose, values, so basically that normalization of the addictive process, and then the presence of co-occurring psychiatric disorders. We know that there's a high comorbidity. It's around 75%. If I have anxiety or depression or PTSD or schizophrenia, I'm about 70% likely to also have a co-occurring substance use disorder, and vice versa. So we think about it like this, that we take a person's genes, their biology, and any present mental health conditions. We look at their environment, both the risk factors and the protective factors. Then I expose that person to the drug, which has its unique set of variables, how the drug is administered, the effects that the drug has, how early in my life do I start using it, how available is it? And that is going to cause some pretty predictable changes in the brain. So then I get physiological changes in both brain structure and brain function. And that is what leads to this thing that we call addiction. So again, you can see it's extremely complex. So just quickly, for those of you that might not be familiar with the particular pathways in the brain that we know change during the addictive process, it's these two pathways, the red line and the blue line. So the dopamine pathway and the serotonin pathway. And these two pathways communicate between what's called the nucleus accumbens or the ventral tegmental area, which is the layman's term for it is the pleasure center. So those are part of our limbic system, the prime part of our system that basically tells us, seek food. That food tasted good, eat more of that. You should have sex, right? You should sleep now. Like that's the part of it's a very primal part of our brain that we tend to not have a lot of control over. What regulates that part of our brain is our frontal cortex. That's the part of our brain that sits at the front that says, like, you should think long term. Maybe that's not a good decision. Let's sit here and read this paragraph and concentrate and pay attention. Those two things regulate each other. So if you think about the VTA as sort of our go sign, like go, 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 have more of that. And our frontal cortex is our stop sign. Wait, slow down, hold off, let's take a minute and think about it. They talk with each other to be able to regulate behavior. The other thing that's happening is all substances of abuse impact the dopamine pathway. And we used to think that dopamine was a pleasure chemical, meaning that is what caused euphoria. We now know that dopamine isn't so much creating this feeling of euphoria as it is a chemical that's vital to learning. So what happens when our brain releases dopamine? So we put a drug into our body and our brain releases a lot of dopamine in response to that drug. What our brain is actually doing is saying, do more of that. That's important. So that's why our brain releases dopamine when we do things like have sex or eat chocolate or foods that have high sugar and fat contents, because that's hardwired to our survival. That dopamine is telling us, remember where that is. So interestingly enough, when we take drugs that hijack this system and we have a huge influx of dopamine into our brain, we're teaching our brain to do more of that's important. Whether it's pleasurable or not is not really the important factor. It's more that this dopamine is being released. So this is an intense learning experience. Taking drugs is actually teaching the brain to take more drugs. This is important to understand because we talked about that frontal cortex being the stop sign. That's the important part of our brain that allows us to manage impulsivity, to delay gratification, to be able to think and be future oriented. Now we know that that part of our brain isn't fully developed until we're about 21 to 25. So what happens when we start to put drugs into the brain prior to that age? And this is why we see that correlation with early use being so predictive of later substance use disorders, is because if you can see the dark blue, the parts that are circled in red, that's the frontal cortex, that's the cortical area. So it's not even close to developed until we get to 20. Earlier in age, it's almost non-existent, right? So what does that mean? It means the earlier we put a drug into the brain, the less likely we are to develop things like the ability to delay gratification, to think through problems in a logical or linear manner, to be able to plan or make good, reasonable choices. Now, what does that imply for our folks that might have been started using at 12, 13, 15, right? It has huge implications. Or what about our folks that might have been exposed in utero, those that were born with early drug exposure? We don't even know the full extent of how it's impacting. But I think that this is an important thing to understand and to get us out or unhooked from this idea that this has anything to do with morality or that this has anything to do with willpower. This is also an example of showing you the structural changes that occur in the brain. This is an example of a methamphetamine abuser. So you can see that this central part of the brain, this is part of the dopamine pathway, so that we just described in the part that tells us that we need to pay attention and do more of that thing. So in a healthy control, where you see a lot of the red and the orange, that means that the dopamine pathway is healthy and intact. So that means that I can enjoy a sunset. That means that going for a walk or hanging out with my friends or going to church is reinforcing because I have enough dopamine availability in my brain for those things to feel good. Now, what happens when somebody's been hijacking that system with a drug over a period of time? You can see a huge erosion of that area in the brain. So what does that mean? That means that somebody who has been abusing drugs has decreased the amount of natural dopamine pathway in their brain. So they can't enjoy things like sunsets. Going for a walk feels like nothing, right? So the things that used to be reinforcing prior to drugs are no longer. This also explains why people develop dependence. I used to be able to take this amount of drug and feel this way. Now I have to take more to get the same effect because structurally, the part of my brain that responds to that drug is actually dying and going away. And this shows us a way of sort of thinking about brain metabolism. So the amount, how quickly our brain works and how it processes the different neurochemicals that it needs to process. We know that a healthy brain, so again, we see a lot of those bright colors and it's full part of the cortex, that means the brain is doing what it needs to do. Now, somebody who's been abusing drugs for a period of time, we see tremendous changes in how the brain is able to respond quickly and to do what it needs to do. Similarly to what we see when we look at people with heart disease or those with diabetes, right? We see that there once a healthy heart compared to a diseased heart, a healthy pancreas compared to a diseased pancreas. We're talking about two different kinds of people. So I think this is important to keep in mind that when we're treating individuals with substance use disorder, we're dealing with an impaired or diseased brain. And that shows up in terms of relapse rates. With other chronic illnesses that have similar physiological changes associated with them. So you can see here, individuals with drug addiction tend to relapse around the same percentage as people with diabetes, hypertension, or asthma. What does that mean? That means that substance use disorder is absolutely a chronic illness and that there are lots of significant similarities to other things that we don't have any stigma for. It also means that we have to consider this huge genetic impact because it's very similar to other conditions like diabetes, like asthma. We don't forget about environmental contributors or personal choice, but it's comparable to those other chronic illnesses. So for example, diet and exercise plays a huge role in the onset and the maintenance of a diabetic or heart condition, right? So it's not that we eliminate environment or personal choice, but it's only one factor. medication adherence and relapse rates are similar, and long-term maintenance treatments are the most effective. That this idea of I go to rehab and I'm going to come out fixed, this idea that I can do 6 months of substance use treatment and I'm going to be fixed, we have to get away from that, the same way we have with other conditions. And probably one of the most important factors that I hope you take away from this lecture is that substance use disorder is the most stigmatized condition. It comes with tremendous barriers to accessing treatment. Individuals with substance use are still perceived as having moral weakness, character flaws. I want you to think about, have you ever asked yourself any of these questions or thought this way about your patients? Are they untrustworthy? Yes, they're going to be criminally involved. They're bad or broken people. That means you're still holding on to some of that stigma. And we see this in medical professionals today. So a recent study done on doctors in primary care and emergency rooms, we asked them what they thought about individuals coming in with addictive conditions, and they said substance use disorder patients should receive less priority in healthcare, that their condition was their fault. So that's a really glaring point, that we still hold this moral perspective. And our patients carry it with them as well. And we know that the more internalized stigma a patient has, the worse their outcomes are going to be. That if they feel bad or broken, or like they're just an addict, always going to be an addict, they're going to feel shame and worthlessness. They're going to be less likely to seek and stay in treatment. They're going to have worse mental and physical health outcomes. They're going to have decreased employment and housing, poor support systems, and this concept of learned helplessness. Why bother? What's the point? I'm always going to be this way. And we know that this has contributed to significant issues with disparate treatment. Substance use disorder is still the only condition in which patients are expected to improve before being accepted into treatment. That there's still a tremendous number of treatment facilities out there that say, nope, we're not going to accept you if you're positive for anything. Or if you're non-compliant while we're treating you, we're going to discharge you. If you think about that, if this was any other condition, would we ever expect a diabetic to have managed sugars before we gave them insulin? That'd be crazy, right? We would never do that to them. It's also the only use disorder where we will withhold life-saving or important medications or ration them. It's the only one where the addictive disease is considered to be a crime or a social problem. We still arrest and imprison people for things like possession and intoxication. And patients are expected to discontinue these effective medications or treatments for most jobs. A lot of like doctors, airplane pilots, teachers, they can't let anyone know that they're in substance use treatment. And if they get drug tested, some of their medications will result in being fired from their position. And there's still a lot of limited issues with insurance or effective health coverage for necessary treatments, particularly long-term and residential treatments. So what does this mean, and what can you do? Well, I think you can carry some of this information with you to think about the language that you use. Instead of things like addict, talk about person with an addiction, right? Instead of things like a dirty or clean urine, think about unexpected or expected. Instead of having things like punishing or punitive policies in place in your program when the disease is in its active state, so for instance, discharging because of positive results or unexpected results, that you should be thinking a bigger picture than that. Definitely, if you're doing any kind of withholding of medication because of behavioral health issues, try to consider that. It would be like withholding insulin from a diabetic. And using or recommending only one treatment or treatment modality can actually cause harm and marginalize already vulnerable groups. So if there's any sort of culture in your program or in your practice where you say, well, if you're not willing to do abstinence only, or if you're not willing to do AA, then that's on you. It's you failed, you need to try harder. Or on the other end, if you're not willing to take opiate replacement therapy for whatever reason, then we're not going to treat you, right? So thinking that we can't force this choice on these people, because how realistic really is it with this knowledge, what we understand about substance use disorder now, to expect these folks to use their best judgment all the time, to delay gratification, especially if they never learned it to begin with, to think long term when their present is so intolerable and their basic needs are not being met, to expect them to make logical, sensible, or reasonable decisions while stuck in a withdrawal or intoxication cycle and while having an impaired brain. Ask yourself, could you do this? could any of us do this, right? These are important questions. So implications: understand that substance use disorder is a chronic illness, that to treat it, we have to treat the whole person, not just their using behavior. We have to think Rat Park. We also want the goal to be improvement, functional improvement, and not cure, because relapse is the rule, not the exception. And we want to be using evidence-based treatments. So we want science to tell us how to help people reduce use, to increase personal health and social functioning, to do all of these good things. And to think about how can we combine all of the necessary things: healthcare, chronic care management, medication, learning new skills, social support, and understanding that there are many, many barriers, and that stigma plays a huge role in how people access and stay in treatment. So these folks need to be treated with respect and compassion at all times. The other thing I want to leave you with is some hope, now that we looked at some of those brain images, to know that the brain can and will heal if the person does what they need to do, that change can lead to significant functional improvement, and people can go on to live healthy lives. So this is something that I always keep in mind. If we look at a healthy person, someone who's only been abstaining for 1 month, and then compared to someone who's been abstaining for about 14 months, our brain does grow back new cells, that our brain is flexible, and that we can get back a lot of the things that we've lost. So don't lose hope. Okay, that's all I got. Questions? Thoughts? Anybody chatting?
Let's see. This would be from before. We're good.
Okay. Well, I hope this was helpful for you guys. Please feel free to email me if you have other questions, or if you have thoughts about anything we discussed today. I very much welcome your feedback. And I appreciate all of the good work you're doing.
I do just have one quick question.
Yeah.
After, the brain starts repairing itself, is there known to be lifetime damage because of the past drug use, or is that able to be repaired as well?
So really, the answer is it depends, right? It depends on the type of drug that they've abused, so how neurotoxic the drug is. So we know that alcohol and methamphetamine are very damaging to the brain, and if depending on the person where they were at their baseline, so sort of how many brain cells they had before they started using, and then how much they used for how long and at what level, there could be permanent damage, absolutely. Does that mean that they can't get some recovery, or even some significant recovery? No, they absolutely can, but it really depends on the substance. Other drugs, like opiates, I'm trying to think of the other, cocaine, they don't have an impact on the brain, but they will have an impact in how the brain is wired. So it's not so much that there's going to be brain damage, but they have to relearn how to live their life. I hope that answers your question, Michael.
Yes, and also, besides, the brain repairing, is there also, with any substance, even if they've been clean for, however long, is there lifetime symptoms of the addiction?
Well, I guess it depends on what you're defining as a symptom. We do know that this is a chronic condition, and it does depend on the person and what they've used and how much they've used and for how long. But we do know that it's something that people tend to have to stay vigilant for, particularly during times of stress. So if you think about, like you've learned to ride a bike, right? You've got real hard wiring in your brain. So you could go 20 years without riding a bike and then get back on that bike, and you might be a little wobbly, but you know how to ride it. So that our brain doesn't necessarily get rid of those learned patterns. So when we think about substance use in a similar way, people have learned how to cope or how to manage distress using substances, and they might have to stay vigilant to that for a lifelong period of time.
All right, thank you.
Any other questions or thoughts people have? All right, well, I recognize that we're at time. Again, thank you guys so much for joining.
I did want to ask before we sign off, the person calling in at the phone number ending with 1744, if you could email me, or if you wouldn't mind just sticking around to give me your first and last name so I can make sure you get credit for today, just because I wasn't able to chat you since you're on the phone.
Okay. Everybody else, thank you again. We appreciate all the good work you're doing in your communities and with your patients, and it means so much that you joined us today to learn about this topic. And again, please come back and feel free to shoot me an email if I can help you in any way. All right.
Thank you.
Thank you. Have a great day.